Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, and thank you for your patience and rearranging the schedule a little bit. So today, Brian asked me to speak about operationalizing use of long-acting injectable ART. I know that there's been some cases already presented, and many of you in the ECHO community are trying to figure out how to incorporate these new medications that people are interested in using into your practice. And I'd be curious to know how many people are already prescribing it. I think when I last asked Hillary about this, she didn't think that anyone had prescribed it yet, but lots of people were interested in doing so. So I don't have any conflicts of interest. As a summary, I know Brian knows this data way better than I do and could present it in his sleep, but I just wanted to summarize some points from the Atlas and FLAIR studies about cabotegravir-rilpivirine, which was studied Q4 weeks. In these studies, Atlas 2M also looked at it in Q8-week dosing, but found that it was non-inferior to oral options that were studied. The injection site reactions were not uncommon, but the satisfaction rates were really high, in the high 90s, preferred IM to PO, and there were low rates of virologic failure in each of these studies. But when it did occur in those rare instances, there was NNRTI and INSTI resistance that emerged, although no cross-resistance to dolutegravir. So we know that they work. We know that people seem to like them in the studies, but what does that mean for sort of real life and how to use these medications, which are not our usual write a prescription and pick it up at the pharmacy kind of medications? So I just wanted to frame it as a case of a 35-year-old woman who's interested in long-acting or antiretroviral therapy, and she's tired of taking pills every day. And I kind of wanted to open it up into how people would approach that conversation with that person and say, okay, would you say that this person would be screened for eligibility? How would you screen for eligibility? Has anyone already done with this with someone? I can't see everyone on the panel because of my screen, so I'm going to ask Brian to let me know if people are willing to share their experience so far. I can tell there's not a lack of overwhelming response, so that makes me feel better that we haven't actually prescribed anyone at our clinic either, that there aren't a lot of early adopters of this yet. So what we wanted to do at the Madison Clinic, and this is work I know G is on, and Jihan also have been really working on how to think through the steps that are needed and how we would screen for eligibility, how we ensure people are eligible, and then how do we ensure people are going to come in for their injections regularly and not have to bridge or not have to restart the maintenance dosing. So this is sort of the framework of what we built, and I'd be happy to hear what other people are doing and share their experience as well, or how they've decided to set it up in their clinic. So what we've told providers, we've had a couple of meetings so far at our teamed with our journal club, and then also just as an educational forum through Zoom, just talking about how we're going to go about it in our clinic so providers are aware, because many people are getting a request from patients about these medications. So what we've told providers is if your patient is interested in cabotegravir-rilpivirine, we want them to review the eligibility criteria. First of all, patients have to be interested. They need to understand that these are monthly visits for 2 injections. They don't come co-formulated into 1 injection. It's 2 different injections, and they're monthly visits. This is not a take it with you on the go type of injection. It needs to be done as a clinic administered injection. That there's still a 4-week lead-in with the oral medications, and the person has to be suppressed for at least 3 months. This is based on the DHHS guidelines for use, although the studies did have people suppressed for 6 months prior to putting them on this medication. So before even putting in a referral or a prescription or anything, we want providers to be aware that this is how they should at least initially approach the discussion with the patient. We also wanted to make clear that there are some ineligibility criteria that we discussed. If someone has resistance, not all resistance is the same, we know, but if people have resistance, that could be a marker of history of non-adherence, history of archived mutations, particularly with NNRTIs, although a K103N, as we know with rilpivirine, is okay. But other mutations would give us pause to say, are there other things that could lead to a failure on a dual regimen with cab-rilpivirine? If they're hepatitis B positive, then we want to make sure that they know that they'd still have to take an oral anti-Hep B agent along with their cab-rilpivirine. So it's not going to do away with all of their pills if that's their goal. I presented some data that I won't go into huge detail about patients who have clade A1 or the L74I polymorphism seem to be the ones that these factors were associated with virologic failure, and there was a recent study showing that if you had both clade A1 and an L74I polymorphism, that you were more likely to have failure. We don't check clade, as you probably know. One French group actually did a study looking at all of the mutations over a 10-year period, and about 5% of people did have a clade A1 mutation. And those French authors actually said it was worth doing clade testing or knowing the clade of your patient prior to starting Cabril. There are no recommendations in the guidelines to do that, though. History of poor adherence would also be a consideration for ineligibility. There is a study right now called the Latitude study for patients with history of non-adherence to try to use Cabril as a means to improve adherence. That data is not available yet. So without that data, it's still challenging to use this combination in patients with poor adherence. We don't have data with pregnancy, so for patients who are pregnant or planning to become pregnant, I would consider that an ineligibility criteria as well. So once you've reviewed sort of all this with the patient, I think the most important part is that people need to understand that they need to come into clinic monthly. This is a big change for what people have been doing during the pandemic, in particular, where many have done telemed or telephone visits, and many of our patients come in, every 6 to 9 months for labs. So this would be a big change in terms of the frequency of them coming to clinic. And I know some of you where you practice, people are driving pretty far to come to some of your clinics to get care. So this may be a significant barrier in and of itself. So G is on, but she actually mocked up our referral to pharmacy, which is about to go live. And this is the sneak peek. Our providers actually haven't even seen it, but I took it from G and I'll show you what it looks like. So basically, providers who have reviewed all the eligibility and ineligibility criteria with their patient and want to proceed with Cabril, put in a referral, and they put in the reason for referral is the Cabril. Then the medications they choose, so it would be a whole standard set as the default, which is the oral lead-in, the initiation, which is the loading dose essentially, and then the maintenance injections. Their most recent HIV RNA, which has to be undetectable within the last 3 months, an HIV genotype that's documented, if there is one, and then Hep B status, as well as pregnancy and conception desire status. And so this would be a way for our pharmacists and a small clinical review team to review the patient's chart and make sure that the eligibility criteria have been met and that there's no ineligibility criteria. Once that is reviewed and it's felt that we should proceed, the program coordinator for our clinic actually will try to obtain the assurance approval through prior authorization. Once approved, the pharmacy will then schedule a visit. Given that we haven't done this yet, and I'd be curious for people who have put in PAs, how long that process is, that's still kind of unknown to me. Then we would schedule an in-person visit to review the medication and then prescribe the oral lead-in. As you all know that you probably discussed, this is not a standard prescription. This is not going to be billed through insurance. ViiV, the pharmaceutical company, is providing the medication for patients and it's at no cost, but we are not going to allow that lead-in to happen until there's formal approval of the injection, so people are not in limbo on the oral lead-in waiting for injections. Then the visit would be scheduled for the loading injection at the time they get their oral medications, as well as the subsequent first maintenance dose. And that would be a visit with pharmacy and nursing to make sure that there are no issues and review any injection site reactions, things like that that may have occurred. One other important thing is ensuring adherence with maintenance dosing. So this is a big concern. There was actually just a paper looking at the barriers, providers' perceived barriers for using this medication. And one of the main themes that came up is how do I ensure adherence and keep track of patients that are due for visits. So we have assigned an RN champion that's going to keep this in our EPIC as an EPIC patient list of all of our patients who are on cabotegravir-rilpivirine to make sure that we know their last visit, their last viral load, when their upcoming visit is. So in a snapshot, we can see who's due or who's pending to be due so that we can remind them of appointments. What happens with missed doses? We want people to feel prepared if they, for whatever reason, they can't come in for their planned maintenance injection, that they have bridge therapy available. If it's unplanned, there is a 7-day grace period per the package insert to get the follow-up injection. But if it's unplanned and it's more than 7 days, then you need to have an oral bridge on hand, or you may need to consider reloading actually if it's beyond that time and they've missed bridging. So it's really important to have these discussions with the patient ahead of time that missed doses mean maybe more oral medications and maybe another loading dose. Jihan Budak actually contacted ViiV about how to get bridge dosing. In some of the studies, they actually just gave up front 2 months worth of bridge dosing just so people are at the time of lead-in. So they had the month of lead-in and then a month just in case they needed bridge dosing. We're not sure how that will work. We have to communicate with the field person for ViiV for our area to make sure that we can get that medication. It's really the cab. It's not the rilpivirine, obviously, because we can just order rilpivirine. It's really the cab that we're talking about. And then how about if people keep missing doses, missing injections? Well, maybe they're not a great candidate for Cabril. And so we wanted to give some guidance about what would make them ineligible, because we really try to, as we've talked about on ECHO before, we often give a lot of refills to people who, are requesting refills but haven't been in a while. But I think this is a little bit different of a scenario where if people are missing injections, there's something that this is not meeting for them, and this is not going to be a great option for them, particularly if they're going to need additional loading doses. Obviously, if they just decide that they want to become pregnant, then that would be another consideration for ineligibility. So that's sort of the framework of what we're doing. And Brian just wanted to bring this up, I think, to talk about it as a forum and what other people have put together for how they're going to implement Cabril in their clinics.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.